Hi, so Module 3, we're going to talk about Part D, prescription drug coverage. And it's basically going to be, Part D basics, who's eligible, the difference between a standalone drug plan and an MAPD, Medicare Advantage drug plan, what drugs are covered, standard and alternative benefits, TROOP, which is true out-of-pocket costs. We're going to talk about the premiums and late enrollment penalties, drug management tools, formulary requirements, enrollee rights, assistance programs, and Part D and other coverage. So there's a lot that we're going to be covering in this Module 3. So drug program basics. Part D covers certain prescription drugs and diabetic supplies, which you'll see also in Medicare, some in Medicare Part B, and then vaccines. It's only through private companies, so a lot of companies have standalone drug plans, and then there's the MAPDs that we talked about already, which that PD part is the prescription drug, so Medicare Advantage drug plan. And then, there's the standalone drug plans. Maybe if somebody just has Medicare, they can have a drug plan, or they maybe have a Medicare supplement and they need a drug plan, or a cost plan. They can cover Part D as an optional benefit. So who is eligible for a Part D drug plan? You have to be entitled to A and or enrolled under Part B. You have to be a U.S. citizen or lawfully present in the U.S. And then you have to reside in the Part D plan service area. There's no health status that needs to be checked. There's no underwriting for the drug plans, nothing like that. And it's, you have to either, like I said, entitled to Part A and enrolled in Part B. So if somebody is eligible to enroll in a drug plan, that'll depend on how they receive their medical benefits. So only people enrolled in original Medicare, Medicare supplement plan, and these other plans, the MSA, PFFS, or cost plan, can enroll in a standalone drug plan. I mean, we'll see that a lot with people that have med sups. They need drug coverage. So a lot of the standalone drug plans that we sell are for people that have med sups. And then if somebody has a Medicare Advantage plan, and I know we talked about this a bit in the last module, if somebody has a Medicare Advantage plan, that's how they get their drug coverage. All right, if you recall, you can't have a Medicare Advantage plan and then a separate drug plan. No, doesn't work that way. So what Part D drugs are included? Prescription drugs, biologics, which are, maybe allergy shots, gene therapies, insulin, and there's definitely some plans as of this year that have what's called the Senior Savings Program, which provides certain insulins at a lower cost. So that's been really popular. Medical supplies associated with insulin, like syringes, needles, that type of thing. And then certain vaccines not covered by B, including shingles vaccine, and then these Tdap vaccines like tetanus and pertussis. So formularies. the process for determining what drug plan is best for someone is, we get their drug list. And what I always advise telling a client is, I'm going to send you this form. I need you to give me your doctors. I mean, that would be for if we're looking for a Medicare Advantage plan, but there's also a spot for their drugs, and we want drug name, dosage, and frequency. And I think a really good idea is when you're reviewing this with a client, ask them to look at the actual drug bottle and copy what it says. What I've seen a lot is people kind of do it from memory, and they might know the dosage and frequency, but they'll say, the brand drug name when really they're taking the generic, or vice versa. So have them look at their actual drug bottle and write down exactly what it says for drug name and then dosage and frequency. I found that to be really helpful. So the formularies aren't going to cover all the drugs. So we use that information that we get from the clients, and then, we put it in the system and see what company is going to have these drugs, preferably on the lowest tiers, because the lower the tier number, the lower the cost. So then we kind of compare, which company is going to have these drugs. First of all, which company has all their drugs in their formulary, because if there's something missing, that's, an issue potentially. But, besides making sure that all of their drugs are on the formulary, which companies' plans have them at the lowest tiers. And the formularies are developed by pharmacists, doctors, and they have to have at least 2 drugs in each therapeutic category. And they're going to have generic and brand names. So there are some drugs that are excluded from Part D coverage, and those would be things that are already covered under B. And there aren't a lot of drugs covered under B, but there are some things that are covered. And this just lists other drugs that are excluded from Part B. Vitamins, things that are over the counter, anything for weight loss, anything non-prescription. So these are all drugs that are not included in Part D coverage. So we're going to talk about the Part D standard and alternative benefits. So there is a standard benefit that Medicare puts out, and it tends to change every year as far as the amounts. One of the slides coming up is going to show the 2022 standard benefit. Part D plans, or if it's a standalone or part of a Medicare Advantage plan, Part D plans can be better than the standard benefit, but can't be worse. And we'll go into that in a little bit more detail when we get to that screen. So all Part D plans, they have to cover at least the standard benefits, okay? And there's different coverage phases. There's a deductible, although not all the plans have deductibles. Frequently, the drug deductibles are for the higher tiers, like 3, 4, and 5. But there's a deductible stage, and then an initial coverage phase, and then the coverage gap, which used to be called the donut hole. That's changed within the past few years. And then catastrophic coverage. And again, there's a screen coming up that's going to give you the figures in those different phases. So alternative coverage, it's prescription drug coverage that's at least actuarially equivalent to standard drug coverage. It's going to have an annual deductible that's not higher. Remember, it can't be worse than the standard plan. It can be better, and many of the plans are better than the standard benefit. The cost sharing can't be higher than what's on the standard benefit. And, some may offer enhanced coverage for an additional premium. So the standard Part D benefits for 2020, and again, there's going to be another screen coming up where this is shown in a little bit of a different format. But in 2022, the deductible is $480. So again, what that means is a standalone drug plan or a drug plan that's part of a Medicare Advantage plan can have a deductible less than $480. Most do. Can't be higher than $480. And it's frequently just those higher tiers, 3, 4, and 5. And then they're going to pay 25% once the deductible is paid, if there is any, 25% of drug costs during this initial coverage phase. Okay. Until they reach $4,430. Now, a lot of people, stay in this initial coverage phase, don't get out of this in any specific year, but some people do, have a lot of drug costs, so they go into a higher phase. And then there's a coverage gap. Now, it used to be when it was called the donut hole, it used to have a higher cost during this phase, but now you'll notice that same percentage, 25%. So during this coverage gap, it's 25% again of the cost of generic drugs and 25% of the undiscounted costs of brand name drugs. Now, we're going to be talking about TROOP, which is the true out-of-pocket costs. So there is no longer really a what they call a gap as far as the beneficiary or the enrollee is concerned, because it's the same percentage, the 25%. But what you want to keep in mind with this is during the coverage gap, drug manufacturers pay 70% of the cost of the drug. So that's the manufacturer discount. And that 70% goes towards the beneficiary out-of-pocket costs, and it counts towards what the amount that they need to get to reach the catastrophic coverage. So the beneficiaries aren't paying for it at 70%, but it does still count towards the amount that they need, that needs to be spent, I guess, paid for by the drug manufacturer in this situation before the person reaches catastrophic coverage. So once the beneficiary enrollee reaches the out-of-pocket cost max, and again, it includes that 70% drug manufacturer discount. Once it reaches $7,050, the beneficiary is through the coverage gap and reaches catastrophic coverage. And then once they reach this catastrophic coverage phase, then their costs are going to be $3.95 for generic drugs, or $9.85 for brand name drugs, or 5%, whichever is greater. So you'll notice that the drugs, once the person reaches this catastrophic coverage phase and they're through the coverage gap, then the costs go way down. Now, this is the screen that I mentioned. There's other visuals that we can show our clients. I don't really love this one, but there's others that I think maybe make a better, better visual to show our clients. But so this is a standard benefit plan for 2022, and the person starts at the bottom at the deductible, and then the person pays 100% of the deductible, and that's if there is a deductible. And it shows that $480 figure, that's the most that the deductible can be. but frequently it's less than that. So they've paid their deductible, probably the higher tiers, 3, 4, and 5 drugs. And then they go into that initial coverage phase, which is the third section from the bottom. And then the enrollee pays 25% of the prescription drug costs until the cost is or $4,430 has been paid. Once that's been paid, then they go into the coverage gap, and that's the section that I mentioned. Drug manufacturers pay 70% of the cost of brand name drugs, and that 70% that the drug manufacturer pays goes towards that $7,050. So that $7,050 isn't what the enrollee has to pay necessarily. There's the drug manufacturer is going to pay 70% of the cost of brand name drugs. And then once that figure has been paid, that out-of-pocket threshold, then they pay, they go into catastrophic coverage, which they're going to pay the greater of 5% of the prescription drug cost, or $985 brand name, $395 generic. So, you know, what someone's drugs are going to cost in any specific year really depends on where they are in these phases. Their cost is going to change. Now, one thing to keep in mind when you're, you know, talking to clients, maybe during the annual election period, or you know, sometimes they're going to have a new Medicare Advantage plan or a new drug plan. You know, frequently what'll happen is they'll maybe forget that there's a deductible on the higher tiers, and then, you know, have to pay higher than they were anticipating. Well, that's because you're paying the deductible. Once you get out of that, the cost is going to go down. So this true out-of-pocket costs, TROOP, what counts towards that? It's calculated on an annual basis. So if somebody reaches their true out-of-pocket costs in 2022, it's going to start over January 1st of 2023. In general, it includes what the enrollee or beneficiary pays for prescription drugs. It includes the deductible, cost sharing, up above the deductible, up to the initial coverage limit, and above the initial coverage limit up to the annual out-of-pocket threshold. And then remember that there's that 70% discount that drug manufacturers pay for brand name drugs after the initial coverage phase, and that will count towards the true out-of-pocket costs. So for drugs to count towards the true out-of-pocket cost, they must be on the plan's formulary, must be purchased at a participating network pharmacy. You know, there are a few that don't count towards TROOP, and that's going to be on the next slide. Okay. So what is excluded from the true out-of-pocket costs? These costs do not count towards that amount to bring you into the catastrophic phase. Costs for drugs that aren't on the formulary, unless there's been an exception under which the plan will cover the drug. Costs for over-the-counter drugs and other non-Part D drugs. Things that are obtained out of network. I know that there's I've heard of people that maybe get prescription drugs at lower costs from Canada. Those aren't going to count towards the out-of-pocket costs. And costs that have been paid for, reimbursed by, you know, another plan. So by insurance or a group health plan or any of these plans listed, including Medicaid. Okay, so these are all things that are excluded from TROOP. So pharmacy networks. Part D coverage is generally provided through contracted pharmacies, network pharmacies. Now, if somebody goes to an out-of-network pharmacy, and not all the plans have in-network and out-of-network pharmacies. But if this specific plan you're looking at does, the person's going to save money by going to a network pharmacy. And something that always surprises me, I guess I didn't realize, and I don't think a lot of people realize this, is that can really save money by changing where you get the drugs. So, you know, I tell this story. It happened to me personally. I had a prescription I had to get for eye drops, and normally I go to Wegmans, and they called me because it was going to be like $300. So they always call if it's expensive, and just to make sure that you still want it filled. So I went online. I went on the manufacturer's website, and there was a coupon. But I had to go to Walgreens. Now, in my neighborhood, Wegmans and Walgreens are right next door to each other. I moved my prescription from Wegmans to Walgreens, and I got it for like $25. That's an extreme example, but you know, you really can you know, find a cost savings by switching pharmacies, or in some situations going to mail order. There are mail order drugs that if you get a 90-day supply and kind of do the math, it's going to be cheaper than getting the 30 days at a pharmacy. So all things to keep in mind. And again, I didn't realize that different pharmacies can charge such a different amount for the same drugs. So there are situations where someone can fill a prescription at an out-of-network pharmacy, but possibly at a higher cost. And that can be if someone is traveling outside the service area, or there's some sort of limited drug access through in-network pharmacies. Okay. So we're going to talk next about Part D premiums and the late enrollment penalty. So, you know, what I've seen is sometimes someone will go on Medicare. They're turning 65, they're going to go on Medicare. And then, you know, they're not on any prescription drugs. So why pay for a drug plan? So they don't get a drug plan. And then, you know, I've seen years down the road where they suddenly have to take prescription drugs, costly prescription drugs, and want to go on a drug plan. And then they find out that there's a late enrollment penalty. So that's what we're gonna talk about next. But Part D premiums, generally there's a premium with a standalone Part D plan. Can't think of any standalone drug plans that are $0 premiums. I'm aware of Medicare Advantage plans that have drug coverage included that are $0, but a $0 standalone drug plan, nothing really comes to mind. I can't think of anything. And then a higher premium means lower out-of-pocket costs. I think that tends to be in general with any of these plans. The more that somebody pays, whether it be a drug plan, a Medicare Advantage plan, or a MedSup, the higher the premium, the lower the costs throughout the year in general. And there's 3 options for paying a Part D premium. It can come out of a bank account by EFT, electronic funds transfer. Someone can get a bill from the plan, or it can be automatically deducted from their Social Security check. It usually takes 2 to 3 months for Social Security to start taking that out. And it can initially be for 2 to 3 months of premium owed, okay, because it takes that long to get started. Then when it is started, they pay for the premiums that have not yet been paid, or they charge for that. And then usually the person has to stay with the premium paying option that they have chose for the entire year. And if they don't choose an option, they'll get a bill in the mail. So this enrollment penalty, Again, I gave the example of people that, aren't on any prescription drugs and think I don't need drug coverage, I don't take anything. If they go at least 63 days beyond the initial enrollment period and they don't have creditable coverage, and remember, creditable means at least as good as what the standard benefit is, then they're going to have to pay the penalty. And the penalty is 1% of the national average beneficiary premium for each month the beneficiary didn't have Part D or creditable coverage. So I looked up to see in 2022, this national average beneficiary premium is $33.37. So this penalty is 1% of that, so 33 cents a month. So you think, 33 cents a month, it's not that much, but I've seen people that have gone years without drug coverage and it really adds up, and they're going to have to pay that penalty. It's tacked on to their premium. They're going to have to pay that as long as they have drug coverage. So if they have the drug coverage the rest of their lives, then they're going to have to pay that penalty. If somebody qualifies for the low income subsidy, they don't have to worry about that late enrollment penalty. So drug management tools and formulary requirements. Usually there's a variety of benefit management tools. One is a formulary. And again, each company is going to have their own formulary. And it's something that we do to help them determine what their best options are. And I say best, that's not a really popular word in the Medicare world, but what are people looking for? The highest benefit for the lowest cost. So we look at their drug list and we see what company has those drugs, first of all, on their formulary and preferably in the lower tiers. Now, the lower tiers, this lists 4. Frequently, there's actually 5 tiers. But the lower the tier, the lower the cost. And that additional tier is actually tier 2. There's a preferred generic tier. So it's generic, preferred brand name, non-preferred brand name, and then specialty drugs. So frequently there's 5 tiers. And other drug management tools, there's step therapy, which I know we talked about in a previous module. Step therapy is trying lower cost drugs before they'll approve costlier drugs. Again, if the doctor says, yeah, this lower cost drug isn't going to work for you, then you look for an exception, you go for an exception. And then prior authorization, the doctor has to request authorization from the plan to cover the drugs, and the doctor has to show that it's medically necessary. Substitution, substituting lower cost generic for brand name drugs if they have, if certain conditions are met. And then this Comprehensive Addiction and Recovery Act program, I thought this was really interesting. So this was a program started by President Obama in 2016, and it was basically to address the opioid addiction issues. So it's limitations on, prescribers or pharmacies to avoid a beneficiary or enrollee the ability to take advantage of their drug plan and to prevent the opioid access. So transition requirements. Somebody's initially enrolling in Part D or switching plans, and there's a formulary change. They have to receive coverage of at least 1 month fill of the prescription, unless they normally get less than a month during the first 90 days. And then that is to, potentially transition them to a different drug. If the person's in a long-term care setting and they're outside of their 90-day transition period, then they still have to provide a 1-month supply, while an exception or prior authorization. So the 1 month could be potentially to try a different drug, or it could be to process an exception or prior authorization so that the plan will continue to pay for that drug. During the transition period, they don't apply the prior authorization or step therapy rules, and then there can be an exception. Okay. So coverage determinations and appealing decisions, I feel like they definitely want you to know what appeals and grievances are that keeps coming up in these modules. But if somebody is requesting a coverage determination and appeal when it comes to drug plans, the plan sponsors or the company has to provide access via a secure website or secure email. And then it's for the enrollee to quickly request a determination of whether the plan will cover a drug or appeal a coverage decision. Okay. They can appeal the coverage determinations or decisions on exceptions or requests concerning tiering or formularies. So what that can mean too is, say someone's specific drug is on a higher tier, they can appeal that and try to get it approved for a lower tier if they have, an approved reason for that change. And then, there's easy access for how this is done. And then again, exceptions for drugs, enrollees have the right to request coverage of a drug that's not on the formulary. Of course, doctors are going to have to get involved in that. If the doctor thinks that the person needs a drug that's not on the formulary, then they apply for an exception. Okay. And then again, grievances. I know we've talked about this a bunch of times. One of the things that I did want to mention is, I think I had mentioned that it was 120 days that someone had for the appeal or grievance process. And I've seen that can be 60 days. So what you want to do is, if you're aware of somebody that's wanting to file, just check and see for that specific company what they're looking at, if they look at the 60 days. But usually that's not an issue. So they can file complaints about the pharmacy, about their drug plan, again, their grievances, maybe pharmacy wait times. They're supposed to, they get their drugs via mail order, and that's been an issue. Hold time on customer service. I mean, people can file a grievance about anything. It's a complaint, but it's not including complaints about a refusal to cover a drug or approve an exception request, because that's an appeal. Okay. So Part D assistance programs. There are a number of programs out there for people that have limited income, limited resources. And I hate hearing when someone says, or you read about people sometimes that, have to decide between taking or getting their prescription drug refilled, or, paying rent or whatever. There is help out there. And these are actually the 2021 figures. So if somebody has limited income and resources, they can qualify for LIS, which is a low income subsidy that can cover all or part of the premium and cost sharing. So again, these are the 2021 figures. I looked up 2022. So 48 states, which is, of course, we're New York, unless you're in Alaska or Hawaii, we're looking at the 48 states. So this is the 150% federal poverty level. In 2021, it was 19,320 for an individual, 26,100 $130 for a couple. That has gone up to $20,400 for an individual, $27,468 for a couple. And then resources can't exceed $14,790 individual, $29,520 couple. Again, this is 2021. It'll give you an idea of what can happen from year to year. In 2022, resources can't exceed for an individual $15,600, and then a couple $30,950. So yeah, it does change typically from year to year, but LIS is definitely something that can be helpful to people. And then if you know of someone that has limited income, limited resources, definitely encourage them to apply. They can go online, they can call 1-800-Medicare, they can call Social Security. There's a phone number here. They can go into their local Social Security office and apply for LIS or extra help to help pay for the costs of their drugs. Now, there are certain people that automatically qualify for extra help. They'll get this magical purple letter in the mail, and those are people that have Medicare and have full Medicaid. They get help from their state Medicaid program paying Part B premiums, or they get supplemental security income. They're going to get this purple letter in the mail letting them know that they automatically qualify for extra help. They don't have to apply. They should keep that letter, and they don't have to apply for extra help if they get it, because that means that they were automatically qualified. So these are the individual costs. If somebody has full low income subsidy, this is what they're going to pay. And again, these are 2022 figures. So if somebody qualifies, they have income at or below 100% of the federal poverty level, resources below the applicable threshold, they have a $0 deductible, and this is their cost sharing. $1.35 for generic drugs, $4 for other drugs. And then this was 2021. This is what the costs were, $395, $984. That was people that were full LIS and full benefit dual eligibles. And then there's different levels. If somebody is up to, again, this is 2022, if somebody is up to full LIS but are not full benefit, I always forget what they're, full benefit dual eligibles, this is what their maximum cost sharing would be. And that's at the 135% level of federal poverty. And then 150, 2022, this is what they would pay. So again, there's a lot of help out there for people that are lower income. Just kind of keep that in mind when you're talking to people, and definitely encourage them to apply. So other help for people that are low income, I talked about my eye drop situation a few years back and saving myself, close to $300. Really, I had just gone on the manufacturer's website. People don't think to do that, but it's, you can do it. You go on the company website, and I've seen savings cards that somebody could qualify for. Now, if they'll qualify for all of those, if they're on Medicare, may not, something to look into. I'm not on Medicare, so that's, maybe that's why I was able to do that, but just be aware that there are low cost options. There's also cards like GoodRx that people can get that can potentially help, and that you can, my understanding is, use that, if somebody has Medicare and it's cheaper to use GoodRx, they can. That's what I've been told. And then there's things like Epic in New York State. It's a state pharmaceutical assistance program. That's what it's called in New York, EPIC. And it can help someone pay for the costs of their drugs. And I always tell people, if you have a client that qualifies for EPIC and there are income limits, have them sign up, because even if they don't use it to help pay for the cost of their drugs, it gives them a one-time a year opportunity to change plans. It gives them an election period, and we're going to talk about election periods in a future module. But if somebody has EPIC, it allows them to change plans one time during the year if they don't have any other election period available. So New York State does have EPIC. And like I said, if somebody qualifies for it, it's a good idea to have them sign up. So how does Part D work with other coverage, employer or union coverage? If somebody has drug coverage through their employer or union, they're going to be told every year, usually they receive a letter in the mail saying that what they have or what they've had in the past year is creditable. Again, that means at least it equals at least as much as the standard coverage will pay. And the purpose of this is to avoid a penalty. If you recall, you have to have creditable coverage. If you go 63 days or longer without it, then you have that Part D penalty to deal with. So, if the coverage isn't creditable, the person needs to enroll in a creditable plan to avoid that penalty. And then if somebody does have other creditable coverage, it's just a comparison. Am I going to save money by moving to this other plan? And again, that's something that I think is worth comparing annually, because formularies change. So employer, again, coverage of drugs. One thing that someone needs to keep in mind is if they have drug coverage through an employer or union and they drop it, they might not be able to get it back. So they want to make sure that that's a good choice for them to change to a different drug plan, because again, they might not be able to get it back, and it could also affect health coverage that they have through their employer or union. And again, this references that 63 days again. So Medicaid drug coverage. When someone is on Medicaid, they become eligible for Medicare. Then Medicare, instead of Medicaid, covers the Part D drugs once the person is enrolled in a Part D plan. If Medicaid beneficiaries don't choose a plan, Medicare will select one for them. So I do occasionally hear from agents, they'll say, my client just got a drug plan card in the mail and they didn't sign up. Well, they got it in the mail because they didn't sign up. And if somebody does get a card in the mail, if they're automatically enrolled, they do have the option of, they don't have to keep that. It's not mandatory, but they will get, automatically enrolled. If they don't keep it, they just want to be careful with that penalty and that they have other drug coverage options. Okay, so this is the end of Module 3. Again, I know I say this after every one. If you have any questions, I totally am aware of the fact that this moves really quickly in a short amount of time. So if something is just crazy, confusing, if you're thinking that, then it's confusing to a lot of people. Just give me a call and we can discuss further until you find it understandable. Phone number, CAFL for me is 585-271-6400. My extension is 101, and my email address is Janine@CAFL.com. Janine is spelled JEANINE @KAF like Frank, L like Larry.com. Thank you.